Hi, this is Dr. Inky Parrack, and welcome back to another Whiteboard Wednesday, where we learn yet another thing about vascular health. So today we're going to talk a little bit more about the basics of vascular anatomy in terms of the arterial system, as well as how it relates to some of the treatments that you should be expecting, whether it be open or endovascular surgery. So first, the blood vessels, it comes out of the heart. So when the heart pumps, the nice, good oxygenated, nutritious blood comes out of the heart, it forms a little question mark around the chest, and then this is now below the diaphragm. Once it comes below the diaphragm, it gives a blood flow to the gut, to the kidneys, and then right around here, it's your belly button. And then after at around the level of your belly button, it splits to go to the right leg and the left leg. And then once it comes down in between that whole segment, this is the groin area. Below the groin area, the blood vessel then splits to go to a little bit more of a deep or posterior system, and another one within sort of a little bit more of an inner interior system, and then around the knee, then it splits to go to 3 different areas. So why is this kind of important? Because I get a lot of questions asked when we're having endovascular interventions, what it is that's going to happen. What do I expect? I don't know about you, but I don't like surprises, especially unknown surprises in a medical setting. It could cause a lot of anxiety. So when you know what's happening, when you know what to expect, it can decrease significant amount of your anxiety. So let's take, for example, number 1. If we do a pretty routine surgery that we do, which is the lower extremity endovascular technology to treat your blood vessels. What it means is when you come in saying, I can't walk, or I have gangrene, or I have a wound that won't heal, or my foot's in constant pain, some of it can be because there's lack of blood flow from atherosclerotic disease, and now we have to go clean that out and get your blood flow to the legs to be better. When we take you to the procedure or the operating room, what's going to happen is that in order to treat, let's say, the left side of the leg, this is a mirror image, so this is the left side of the leg, what you will experience is that we're going to go from the right groin. The reason why we do that is we go from the right groin, the blood flow goes up and then over, because if I puncture the left groin, I'm going to miss this huge segment of your artery that feeds the left leg between the belly button and your groin area. We don't want to miss any part of your artery that's feeding that whole entire left leg. So we want to look at all of it from the get-go. So that means we go from the contralateral side, or the opposite side, and that's where the puncture and the numbing is going to be. So don't be scared if you go into the operating room and you think the doctor might be operating on the wrong leg. This is the way that we do it so that we don't miss any portion of it. And then throughout the whole entire process, we're going to see if there is any significant vascular disease. If there's significant vascular disease, then we're going to treat it all along the way. So let's talk about some of the more important aspects of dividing these anatomic landmarks and what it means. So your doctor may come in and say, oh, you have artery down in the calf area that's bad, or some might say you have artery in your thigh area that might be bad, or you have iliac arteries, which are in your abdominal area, that might be bad, or that is the most important culprit for you not having blood flow. All of these different segments have different outcomes in terms of how you're going to do. So for example, if you came in and your significant blood is atherosclerosis is in the aorta iliac segments, a lot of times if we're able to fix that, especially in an endovascular, minimally invasive way, you're good for 10, 20 years without really even blinking an eye. A lot of my patients are very sick when they come in. They can't walk. They're so weak that they've been kind of bed bound for like a year, and then they get this treatment done. They didn't even know that this was the cause. And then they go around walking, they don't have to worry about anything. Conversely, if some people have most of the disease below the groin, those are in some ways easier to treat initially. However, once those are treated, there's a big portion of the patients that may require a touch-up, more medications, another intervention in order to make sure that you have an adequate upkeep. Because of that, you might find that some of, when you come see me as a surgeon, I might encourage you to do a lot of other things, such as walking and exercise therapy to promote your own body to form some of these blood flow connections so that when we have to do an intervention or when we have to operate, the outcomes are optimal. So this was Whiteboard Wednesday so that we can figure out your anatomy, and the more you know, the better you're going to be educated and less anxious.